spoke about all these instruments, and we know that intraocular pressure is central. They all have issues. So what can we do to make sure that whatever IOP we are getting is as close to accurate as possible? So there are multiple factors which we need to consider that include patient, instrument, and procedure-related factors. We'll take them one by one. Some of the patient factors that you have are inherent, and some of them are modifiable, some of them are not. Some which are inherent are like the ocular pulse or the diurnal variation. The ocular pulse we spoke about multiple times. We'll deal with it a little bit more. And diurnal variation is something that I'm going to touch upon just very briefly. Don't forget that your intraocular pressure reading is just like one clip from a movie. If this is what you're seeing in one frame, the next frame could look like this. Intraocular pressure can give the same sort of surprises. You can go from 12 millimeters at 2 o'clock in the afternoon to maybe 24 millimeters 2 hours later. And you must remember that checking it at multiple time points does help. If you look at other modifiable factors, you have something. None of us is going to do applanation tonometry on a patient who's looking like this. You know it's going to be high. Any Valsalva like maneuver is going to cause us to go up. But if you have patients with necks that look like this, who are sitting at a slit lamp, that also induces vascular congestion. It's a Valsalva like maneuver, and you are going to get high pressures if the patients are not absolutely comfortable. Same way, putting a child with his neck out there and pushing him there is also going to cause a Valsalva like maneuver. Or if you work in New York and wear very, very tight neckties, that itself can cause pressure to go up when you're sitting at a slit lamp, because that tightens it over the neck, it impedes venous return, and it causes, in addition to damage to the eye, it can cause a transient rise in intraocular pressure. We could not replicate this in our own population, maybe because we weren't tying the ties tight enough. So how do you minimize patient factors? You check intraocular pressure at multiple times. You make sure the necktie is not too tight, and in patients with very thick necks or obese, make sure they're seated comfortably at the slit lamp. Look at instrument-related problems. All of us spoke about central corneal thickness. We spoke about inter and intraocular variability. And for the Goldmann applanation tonometer, you can expect a 3 millimeter variation in intraocular pressure if two people check IOP 30% of the time. 70% is less than this. And you see a 2 millimeter change in intraocular pressure if a single observer checks IOP multiple times in more than 35% of eyes. One of the other things that we found which was interesting was that we compared two brand new Goldmann applanation tonometers made by two different manufacturers, calibrated perfectly on the same patient, same day, within 2 minutes of each other. And what we found was that one of those tonometers consistently gave 2 millimeters of mercury higher than the other, and the range of difference between these tonometers ranged from -2 millimeters to +6. So same principle, two different manufacturers, perfectly calibrating brand new tonometers. This is the sort of difference that we found. So it tells you that even with the same device, you might have issues from time to time. Central corneal thickness, everybody spoke about, and I'll just emphasize one point here, saying that you see a lot of correction formulae for central corneal thickness. And this is what happened to the ocular hypertension treatment trial. What you see in this gold, in the white graph there, is a spread of central corneal thickness values in the ocular hypertension treatment trial. And each of these other graphs is what would happen to those values if you apply different corneal correction factors. And you see that the graphs change dramatically. So no single perfect nomogram exists for correcting central corneal thickness. You need to have an idea of the central corneal thickness to know how reliable your measures are. If you look at central corneal thickness on non-Goldmann applanation tonometers, all of them are affected to some extent or the other by central corneal thickness, with the possible exception of the DCT, which may be the least effective one. So how do you minimize this? You measure CCT in all glaucoma suspects and sort of categorize that as high, medium, or normal. What about ocular pulse? The problem with the ocular pulse is during one cardiac cycle, your intraocular pressure can vary by as much as 4 millimeters of mercury. So if you have taken the pressure at the top of the cardiac cycle, you are getting a much higher IOP than if you have taken it at the bottom. So you need to take multiple measurements in any instrument which has very short measurement times. In terms of calibration, Dr. Ronnie dealt with it, and I'll just reiterate that when we looked at our own instruments in our own hospital, we found that if you look at the manufacturer's recommendations, and these are tonometers which are calibrated on a regular basis, 96% did not meet the manufacturer's guidelines for accuracy. But if you look at our own protocols, or if you look at the CD protocols which are more reasonable, 70% of those instruments did. So based on our own information, now we calibrate almost every 4 months, and what we also recommend is that first thing in the morning when you come, just slide the knob back to 0 and see whether your tip moves back. And then just move it forward. If it moves forward, you at least know that it's accurate at 0 millimeters. And that's something all of us need to keep in mind. Calibration is a problem. If you want to get the instrument rectified, you have to send it back to the company. There are some ways of doing things a little more simply, and hopefully we will have some data on that out in publication soon. So calibration is required for multiple devices. If any of your applanation tonometers requires calibration, please calibrate it. It probably needs it. And monitor the calibration regularly. So again, how do you minimize variability? You take 2 consecutive measurements at each visit. And if those 2 consecutive measurements are more than 2 millimeters apart, you take a third reading and use the middle of those 3 readings as the intraocular pressure that you record at that time. If possible, take multiple diurnal measurements and also measure central point thickness. Have an idea for the normal range of the central point thickness in your population. It tends to vary between rural and urban populations, and you should know where your patient falls in any of these 3 categories. When you're looking at long-term follow-up, as far as possible, use the same observer. If you can't use the same observer, try and use the same instrument, because inter-instrument equipment differences do occur, and they will have an implication on your management. If you cannot manage to do that, and even if you can, make sure that all your devices are calibrated. And just last but not the least, please check intraocular pressure in a physiological position. If you check it in somebody like this who's doing a headstand, the IOP that you record is probably double what normal is. So thank you, and that is the last. Could I request all the faculty to please come?